Hello, and welcome to Investing in Our Future. This is the case for a new EHR system at the Independence Medical Center. This is a leadership specific podcast at Independence Medical Center. Welcome to Independent Insights. Today, I am your host, and we are going to discuss something that concerns each and every individual who enters our doors, be it a patient, a provider, or a staff. Our electronic health record system is called that. Here's the honest truth. We have an existing Opus EHR system which was put into operation in 2008. Think about that for a moment. The iPhone was the new product released in 2008. Netflix was continuing to mail DVDs. And this is 2026, and we are still using the same technology that is almost 20 years old. It is as though you have to use high school shoes in a marathon. Of course, they are technical issues, but they are not doing you a favor. I just have an opportunity to meet with stakeholders throughout the organization, including the C-suites and up to the ICU floor. I heard the same concerns raised many times: interoperability issues, workflow inefficiencies, documentation headaches, and probably the most important, lost chance in patient care and money saved. I am now making the argument of why investing in a new and combined AHL system is not just a new technology upgrade. It is a future-oriented investment in our financial future, our clinical performance, and the well-being of our community. We can deconstruct the figures, the anthropological influence, and the way ahead. So, what's the financial reality? What's at stake? I would like to begin by some numbers that disturb me at night. Our CEO, Norma Reynolds, has pointed out that preventable readmissions cost us about $7,200 a case. Assuming that readmission rates will be lowered by 100 patients per year due to a better care coordination and discharge planning made possible by a state-of-the-art AHR, that is more than 720,000 saved. Last year, the average CMS penalty was 125,000, as told by our Chief Nursing Officer, Dan St. John. It is money that out of our organizational money that can be used to purchase new equipment or staff training or programs that support patients. We could prevent these penalties by completely improving quality measures and minimizing readmission, at the same time achieving improved patient outcomes. Next, there is a staffing side. The ICU's Deborah Green informed me that we are paying overtime of more than $1.3 million every year. Even with a minimal 15% decrease in the cost of better staffing predictions with HR analytics, a savings of almost $195,000 a year will be achieved to improve nurse burnout and satisfaction. Aaron Johnson was reminding us that the pharmacy is 13% of our operating budget, and 80% of that is actually drug expenditure. Integrated decision support will save money by improving medication control and decreasing waste by saving up to $250,000 a year. According to Matthew Allen of the lab, eliminating unnecessary testing by enhancing orders sets will save additional $15,000 to $20,000 in a year. Once you begin counting these amounts, we have a potential of saving and increasing revenues in excess of $1.8 million every year. But here is the point. These are not mere abstract figures. Every dollar that is saved is a dollar that can be used to reinvest in the patient care, staff support, community programs. The lack of interoperability is a direct cause of care coordination failure that complicates the process of care delivery by making it more expensive and risky. So what's the clinical productivity gap? Our chief medical officer, Patricia Darren, told me something that stood out with me. Since we had the last implementation of the system in 2011, the productivity of physicians decreased and never returned fully. In the current situation, our infectious disease physicians have an average of 4,200 work RVUs annually, which should be 4,800, which should have been 4,800. Even covering half of that distance to even 4,500 RVUs will produce another 50,000 in inpatient service revenue each year of only a single specialty group. Consider that of all our doctors. The total effect is high-reaching to about 350,000 a year. Research supports this. It has been demonstrated that the properly designed AHL system may, in fact, increase the productivity of physicians and adherence to guidelines instead of obstructing them. The gains, however, cannot be attained without an appropriate system and, more importantly, the appropriate implementation strategy when our stakeholders are engaged to the fullest. Patricia has pointed out that the input of physicians are buy-in are key to success. Three strategies for stakeholder buy-in. You all are thinking now, what can I say? We have heard promises before. We've spent a lot of money on our previous system and have not recouped the expenditures. This is what our CEO, Gwendolyn Zima, was open about, and she has rightfully been worried. This is the reason why stakeholder communication is not merely a luxury, but a must-have in order to become successful. Three ways of making sure we do this right, I'll tell you them. One, to begin with, core design sessions with frontline staff will have to be put in place. We have to have cross-functional teams such as nurses, physicians, lab technicians, and admission staff all working together and inquire of them what will make their work easier and safer to patients. When employees are listened to and their contribution is considered, the adoption rate is high and the resistance is minimal. Secondly, we should all have an open financial communication. Linda Bradford emphasized on the importance of stakeholder input that makes decisions that affect our bottom line and reputation, sharing the cost benefit analysis with the department heads and clarifying how long-term savings will far exceed the initial cost will establish trust and make allies of success. Thirdly, we need to make sure that we have different representations in decision making. This is not a box ticking game, but about appreciating the fact that various stakeholders have their own views. This is by making sure our implementation committee is diverse enough to represent our workforce and community, enabling us to create a system that works, that everyone can work with. Not only is that inclusive, but it's good business. Now let's talk about the cost benefit analysis by the numbers. Our HR system will cost 4.83 million as it is comprised of software, hardware, training, productivity, transition maintenance, and contingent reserve. Annual benefits occur at 1.8 million through readmission reduction, physician productivity, pharmacy savings, overtime savings, claim denials, CMS penalty avoidance, and lapse optimization. Thus, this provides a payback period of only 2.6 years and a cost benefit ratio of 1.92. So when we look at this, without we will have a cumulative benefit of 9.29 million without taking into account enhanced patient satisfaction and safer medical care. So let's talk about the human element, why this matters beyond the numbers. This is an investment in the ED of Ruby Martindale, who is in need of appropriate reports in the cases of crisis in the ICU. You know, we have Deborah Green, who is seeking ways to help prevent nurse burnout, and Matthew in the lab wishing to see waste reduced but quality remain where it is. The current AHR links the caregivers to vital data in real time, lessen cognitive burden, and also provide staff with assistive resources. It is community well-being, and then Norman Reynolds remind us so. Each admission prevented, each readmission prevented, and each medication error avoided is a patient who receive increased care, a family that is less concerned, and a healthier community. So I am requesting the board to endorse a multidisciplinary EHR selecting committee, a request for the proposal to qualified vendors, making a commitment to transparent stakeholder involvement during implementation, and spend the 4.83 million in capital resources. The sensitivity analysis verifies positive returns even in conservative situations. The warning Gwendolyn Zima gave us regarding investing in the past is not undeserved. However, this time we are establishing a business relationship with our employees and community to revolutionize care delivery. We are grateful to you as a leader. We will be able to construct a healthier future of the community. Thank you very much.